I am pleased to introduce Dr. Anand Gupta. He is a senior consultant in critical care in Asian Institute of Gastroenterology. He has 12 years of experience in critical care medicine. He is specialized in transplant critical care and neurocritical care, and he did almost have experience of 2,500 solid organ transplant. Sir is skilled in point of care ultrasound. He is one of the instructor of InFocus ultrasound course. His area of interest was ultrasound in critical care, ECMO, advanced hemodynamic monitoring, and ventilator. Uh, Please join me in welcoming Dr. Anand Gupta, sir.
Good evening, everyone. Myself, Dr. Anand Gupta. I am a critical care specialist. First of all, I would like to thank to the organizing community for giving me this opportunity. Today, I am going to discuss very important topic, that is a circuit and pump. You should know as an intensivist, once as a ECMO physicians, which kind of circuit you are using. So you should know everything about that circuit, like physics, designs, and performance. So circuit, there's a different kind of the circuit, different parts in the circuits like pump, PVC tubing, polycarbonate connectors, and the membrane lungs. So we'll little discuss about the ECLS, the history, the devices. So there are membrane lungs. There may be the solid silicon rubber, microporous hollow fibers, and solo hollow fiber. And the pumps are also the roller pump and the centrifugal pumps. So we'll discuss first about the pumps. The machine that transfers energy into the fluid system. Pump have a shaft and an impeller. Impeller is the rotating element. It behaves like an artificial heart, pulls the blood either from the venous reservoir or directly from the patient, pushes it through the oxygenator back to the patients. So different kinds of types of the pumps. Radial flow who went through the radial flow is a fluid flow toward the outward side. Is a right angle to axis. It's called a centrifugal pump. And then mixed flow also is like a centrifugal pump. And axial flow, fluid flow spirally along the axis is the propeller pump. So there's, as you can see, there's a B, C, all three diagrams. Because the A type is a roller pump. It's a basically occlusive pump, and the B is the impeller pump, and there's a kind of fan kind of thing, and C is a centrifugal pump. So roller pump. So it is an occlusive pump traditionally used for the cardiopulmonary bypass. What are the mechanisms behind that? So works for the compressing the tube. So it will compress the tube, thereby pushing the blood through the raceway tubes. It pushes the blood by positive displacement through the oxygenator back to the body. The blood from the venous reservoir, is pulled into the tubing by the negative pressures. What are the silent features in this roller pump? The output of the roller pump is dependent on the size of the raceway tubing. Larger diameter tubing are preferred as it reduces the RPM and wear on the tubing. Occlusal pressure of the roller, pump RPM, blood flow. And flow is calculated based on the length and the diameter of the tubing in the pump raceway and the pump RPM. Occlusion must be set appropriately to ensure that the proper volume is moving through the tubing with each revolution. Operated manually in case of power failure by using the hand cranks. There's some advantage or disadvantage. So advantage are the constant flow provided by the volume displacement and is not dependent upon the afterload conditions. This is a very important, because this is the disadvantage of the centrifugal pumps. The priming volume is less than the centrifugal pump. Lower cost, but need a more experience. What are the disadvantages, which is more important, is the tube ruptures, because it is occlusive. So sometimes tube may be ruptured if the clamp is there. The liberation of the plastic particle from the tubing in the pump raceway, which may embolize in the patient. Too little occlusion will give the falsely elevated flow calculation and may lead to malperfusions. Too tight of an occlusion may lead to the increased aspirations, hemolysis, and the raceway rupture. The history of the centrifugal pump. The first centrifugal pump in the 17th century used by the Dennis Papin. The first application of blood pump in 1980 using the Medtronic centrifugal pump. ECMO initially employed the roller, but rest after that the centrifugal pump popularized more. Numerous centers now prefer the centrifugal pump technology for the ECMO. First and second generation centrifugal pumps generate higher friction and heat, leading to the greater hemolysis. Newest generation pump have a single point, joint bearing, magnetic levitations, improved flow dynamics and mechanical efficiency, very low friction, negligible heat generation, so very low hemolytic index. So less chances of the hemolysis are there. The centrifugal pump are non-occlusive. The pump flow is not constant. So preload and afterload are dependent. So flow may be variable at a set RPM. So depend on pump preload, pump afterload, size of the biohead, pump head. The flow will reduce automatically in case of decreased preload or increased afterload. Can be operated with the hand crank and has a battery backup. Advantage of that, it requires less positive pressure to move a volume of the blood. It can trap the small amount of air in the constant vortex of the blood within the pump head. More forgiving technology, avoid extreme buildup of positive pressure, elimination the risk of the raised bed ruptures and aspiration. Low frictions, lower index of hemolysis, especially in the new generation pump. But what are the disadvantages? The flow decrease as the resistance to the outflow increase. So the flow can be decreased due to the rise in the SBR or BP, kink in the arterial cannula, and the compressing the chest cavity as you roll on the patient, and the cavitation is the one of the important disadvantage in this pump by generating the significant negative pressure and is directly proportional to the roller pump speed. So there are different kind of centrifugal pump by the Mackay, Meadows, Medtronic. These are available in the markets. We'll discuss little bit about the each pumps. First, the Medtronic is called the BP80 or 50. The prime volume is the 80 and 50 ml as the adult and pediatric pump. No coating, up to 7 liter. Up to 7 liter is a maximum flow. Heat generation and hemolysis rate higher than the no higher after the 1 week. And the revolution, the Sorin is the prime volume is 57 ml, is made up of the phosphorycholine, biocompatible 8 liter maximum flow, low friction bearing. Hemolysis rate is compared to Josta flow is less. And the low heat generations. Another is a McQuay Josta flow. Prime volume is 31 ml, circuit heparin coated. So flow rate is up to 10 liter. Up to 10 liter. 1 point bearing, hemolysis and heat generation is very low. Another is a CentriMac pump. Is a prime volume is 31 ml and 14 ml, up to 10 liter in an adult and up to 3 liter in the pediatric. Bearing less, pump least hemolytic index can be used for LVAD, RVAD and BIVAD. Diagonal pump with the Meadows is the minimal priming volume. 16 flow range from 0 to 8 liter per minute, reopen coated, bearing less pump, plastic pulsatile flow optional. So these are the some kind of centrifugal pump monitoring pump function. We need to monitor pump by the auscultation to see the RPM, flow relations, pre-pump and post-pump pressures, and some evidence of the hemolysis like hematuria. So these kind of the pump related issues you can evident once you will closely watch on that. The oxygenator. Now we'll discuss about the oxygenator. So there are different kind of oxygenator. There is a pseudo oxygenator. These are hollow fiber and plasma type. Another is a membrane oxygenator, silicone oxygenator, bubble oxygenator, disc oxygenator. So little bit history, Lil here and D. Wall developed the bubble oxygenator in 1955, which was usable for 1 to 2 hours. And Cameron and Mayer then after a few years developed the silicone rubber successfully used for the color blow in the lab. And then after they may use for the bypass for days, at least for the days. What was the disadvantage of this polypropylene hollow fiber oxygenator? Disadvantage is plasma leak. Plasma leakage of the plasma to the gas phase present as an outfeeding of the serum containing form and the decrease in the serum in the oxygenating capacity over time. This failure is reported to occur more rapidly when lipid containing fluid we are giving and last for the few hours to days. So there are different kind of oxygenator, membrane oxygenator, hollow fiber oxygenator, and pseudomembranous oxygenator. So membrane oxygenator are the silicone consist of single lone envelope, sorry, made up of the silicone with the gas ports at either end, non-microporous, no blood gas contact, outer blood phase, and inner gas phase, physiologically inert, biocompatible, durable, antithrombogenic. Gas action capability is rated to in terms of the square meter. Limitations are a high chance of clot formations due to higher resistance of the blood flow, increased priming volume. Another hollow fiber oxygenator, they are the direct flow gas oxygenator, easy to debubble, get plasma leak over. Another is a pseudomembranous, which is the plasma type polymethylpentene. These are less microbubbles, less plasma leak, less platelet aggregation, minimum hemolysis, currently gold standard and the good long term. Different kind of oxygenator, Meadows, Jostra, Sorin. So according to their priming volume, maximum fluid, coating, how many days is recommended. So they are different kind of oxygenator. The functional assessment by the delta pressure is a difference between the pre-oxygenator pressure and the post-oxygenator. Increasing delta pressure is some kind of resistance in the oxygenator which indicate the clogging of the oxygenator. Post-oxygenator blood gas is another important for the functioning. If the post-oxygenator blood gas is less than, it should be more than 200 and the PCO2 of 35. If less than 200, that means to say some kind of clogging is going on. Tubing should also be selected depending on the desired flow you want. The tubing used must be resistant to the increasing and the possible erosion. Tubing depend on the coating, like a regular means no coating, heparin coating. In the Medtronic and Mackay, soft line, which is heparin and albumin coating, preferred to use in the patient who was going for underwent recent surgery, bleeding diathesis, or actively bleeding or high risk of the bleeding. Safe align, which are the albumin coated. Depending on the material, is a PVC, sandwoven, super Tygon, and non-DHP. So different kind of material we are using for the tubing also. Tubing size depend on the 1 by 8 inch, 5 by 3, 32, 3 by 16, 1 by 4, and 3 by 8. And that according to what stroke volume, prime volume, and the maximum arterial and venous flow is you can drain out, it can be seen. So mostly 3 by 8 inch generally in adult. Type is the ECMO heat exchangers. We'll go to the type. There are two kinds, ecmotherm and the biotherms. Another is important, it is a beta bladder. It's a small compliance chamber within the venous circuit, facilitates servo regulations. Otherwise, right atrium would serve this role. Bridge, there's a three kind of traditional bridge, screw bridge, and then the stopcock bridge. The located near the cannula and its connections between the arterial and venous limbs of the circuit. Allow patient to be isolated from the circuit while a blood flow is maintained to prevent the stagnations. So as you can see, two different kind of clock, this stop clock and the screw clamp. So another is cannula is the airway in the ECMO. If cannula is removed, and mean to say airway, you have this like airway in the ventilator patient, airway will be out, mean to say that now there's a difficult condition to maintain, like the cannula in the ECMO. Cannula selection consideration. So match cannula to expected flow. What flow rate you want? So drainage cannula should always be bigger than the return cannula. Under pressure is more damaging than the over pressures. Consider the use of special cannula like smart cannula, Avalon cannula. So arterial cannula, according to weight, you can select the cannula size. Like a venous cannula also you can select according to the size. So there's a double lumen, there's a two drainage port for the IVC and IVC, usually 2/3 of the cannula diameter, one return port situated between the two drainage port. In the design in a such way that it remains in the right atrium opposite to the tricuspid, usually 1/3 of the cannula diameter. So it's a different double lumen cannula available are Avalon, Origin, Paraglides, and that according to the size, you can patient weight, you can select the size, maximum drainage, and the return part. Circuit has two limbs, venous and the arterial. Venous limbs is considered of following part in sequence, like bridge, plus minus connector for the monitoring of the venous saturation and the hematocrit, pressure line for the monitoring of the pre-pump pressures, three-way connector for the HD, return if required, beta bladder, especially in roller pump, centrifugal pump, or raised tube for the roller pump. And then arterial limbs consist of following part in the sequence: pressure line for monitoring of the pre-oxygenator pressure, oxygenator, pressure line for monitoring of the post-oxygenator pressures, three-way connector for HD, input if required, flow sensor, and the plus minus bridge. Circuit preparation. Every center should have their own custom-made circuit. It must be configured with the option of total support being available. Circuit length. The shorter the circuit length, the better. Tube length to be decided as per the space around the bed and the size of the bed, whether patient require transport or not. Because if the patient require transport, you need little bit bigger size of tubing. Circuit preparation. The length of the circuit is responsible for resistance. Directly, more length, more resistance. The foreign surface area, more the length of the circuit, more will be the exposure of the blood to the foreign surface, resulting in increasing prion volume, increasing heat loss, increasing the protein and the drug binding to the circuit might lead to the increased such reactions. Preparations. Usually larger diameter tube is used for the drainage as a venous limb as compared to the return. Minimize the connector as they lead to turbulent flow and the possible stagnant area where the clot formation. Oxygen to be decided on the basis of total flow expected. Indication is the ECPR, hypothermic coagulopathy, required polypropylene. Availability. The membrane lung must have a rated flow higher than the maximal anticipated blood flow. Circuit, we will not discuss in detail. There are different kind, VVV ECMO, VAV ECMO, dual oxygenator, coated circuit. Advantage, heparin coating will reduce the systematic heparin requirement, reduce the surge reactions. Heparin coated, bonded, covalent or ionically to minimize the blood surface reactions in Medtronic and Mackay. Aluminum coated both the reduce the surge reactions in example like soft line and safe line. Priming is depend on the priming volume and then solutions. Volume is depend on the what is the volume of the pump, what is the volume of the oxygenator, and the volume of the tube length. Circuit priming. The circuit is primed in two stages. The circuit is primed with the crystalloid, ringer lactate, and plasma lactate. Additive are then include depend on the blood gases and the age of the individual patients. Blood product, and albumin may require, will depend on that these. Crystalloid priming first. First de-air the pump and then oxygenator. Once de-aired, let the pump run with the RPM of around 1500 for the few minutes to get rid of the microparticles. Then prime gas phase of the oxygenator with sweep gas of 2 liters per minute. Now add additive if required. CO2 flush to displace any nitrogen which would form the bubble for silicon oxygenator. A saline clear prime is used to displace the CO2. Priming the circuit, the system is debubbled during the circulations through the oxygenator. Albumin may be added to decrease the fibrinogen adsorptions during the initial blood exposure in older children and adults, and in some neonatal emergency. ECLS is initiated with the clear crystalloid and the albumin prime. For adult patient, blood priming is not required unless hemoglobin is less than 10 gram %. For pediatric and neonatal, physiological priming composition is needed. Albumin priming decreases the loss of the coagulation factor and the protein absorptions by the circuit. When blood is used for priming, give 1 milligram of calcium gluconate with every 1 ml of the blood. Priming with the FFP is recommended when supporting children post-cardiotomy to prevent further dilution of coagulation factor and antithrombin 3 factor. The gas priming with the gas flow of 1:1 at 21% of FiO2. For neonate less than 6 kg of the kids, additive priming should consist of 50 ml of blood, 25 ml of human albumin 20% or 50 ml of the FFP, 4 ml soda bicarb, and 0.5 millimole calcium gluconate. And the pediatric between 6 to 20 kg, additive priming should consist of 70 ml of the blood, 30 ml of human albumin 20% or 50 ml of FFP, 5 ml soda bicarb, and calcium gluconate 1 ml. Thank you.